Okay, ladies and gentlemen, we are going to hop into psychological disorders today. Hooray! Uh, this is sort of where the rubber meets the road in psychology. We've talked all semester about the different perspectives that we bring to bear, that different researchers bring to bear on psychology, and what does that mean in terms of how our brain works and how our behavior happens. But at the end of the day, what we're really most interested in is helping people. And so, one of the primary reasons that the field of psychology exists is so that we can provide services to people who are struggling and would like to change their behavior and don't know how. And so, in one way or another, we um, try to provide those services. Now, we'll talk about therapies in the next chapter. How exactly do we help out folks who are struggling from different disorders? But this week, we're going to talk about the disorders themselves so that we can understand exactly what we're talking about when we then get to treatment. Okay, so in order to understand um, psychological disorders, we need to first understand what abnormal behavior is. That's surprisingly difficult to nail down a definition of abnormality because there's different ways that you can approach it, right? There is, let me move my slides so that I'm actually looking at something that makes sense. Um, there is the definition of abnormality where you were talking about something that simply doesn't occur very much, something that is statistically uncommon, as these slides say. Um, Now, that is one way to look at abnormality. Somebody who does something that isn't usual is one way to look at abnormality. That in and of itself, while there are elements of all of these definitions that we use within psychology, that being uncommon is not sufficient for a behavior to be considered abnormal and necessary to receive treatment. Um, there's lots of things that are statistically uncommon that are nevertheless not problem behaviors, right? Statistically speaking, being the president of the United States is a statistically uncommon behavior, right? There's only 45 people who have held that post. In fact, only 44 because there was somebody, I want to say it was James Garfield. I'm wrong about that. I can't remember who was both the 24th and 26th president. So he got in there twice. Whatever. You get the point that I'm trying to make. It's not a problem to be a president of the United States, depending on who you're talking to, but it is an uncommonly occurring event. So that in and of itself is not necessarily a problem, right? Now, a more common way to define abnormality is any behavior that is not culturally accepted, right? What is a behavior that just simply isn't acceptable in your society? Now, I've got plenty of stories about this. The one that I always like to tell, though, is about my brother. I'm the youngest of five brothers. We all grew up here in Utah, or at least we moved here when I was young, and my brothers were still in their teen years. At any rate, this particular brother that I'm talking about went to BYU as an undergraduate student, and I don't know if you've ever been there, but they have their Museum of Art, right? Up on the second floor, sort of overlooking the museum, there is a cafe. And it is like most museum cafes, I would imagine, in that there's soft classical music playing, and everyone is speaking softly, and it's a very urbane environment. You hear the clink of silverware and this gentle murmur of voices, and it's all so very, upscale. Whatever. He was there as a student, grabbing some lunch with his friends up in the cafe. And I don't know how the conversation turned in this direction, but one of them said, "I bet you $5 that you will not just freak out right here in the cafe." And my brother's like, "Well, I could use $5. And so he throws himself over backwards in his chair, falls onto the ground, starts writhing around and screaming, yelling, the bees, they're all over me, get them off of me. He hops up and runs over to another table and like grabs somebody's fork and starts raking it down his arm. Get them off me, get them off me. And he's like freaking out. And turns around, accidentally smashes somebody's cup off of the table. It shatters, and he runs out of the cafe and out of the museum. To hear him tell it, everyone else in that cafe at that point was utterly frozen. They had no idea how to respond to him, right? They just froze like deer in the headlights. This is not cafe behavior. What are we supposed to do with this? Is this person insane? Am I in danger? I don't know what to do. And so everybody just stares. What ended up happening was that he went next door to another building and sort of hid there for a little while in sort of the common area. And one of the Museum of Art security guards followed him. Turned out to be a friend of his. It was another student who was working at the museum. And he comes up to him and he's like, hey, dude, was that you in there? And my brother's like, yes, it was just a silly bet. They said I wouldn't do it, and so I did it. I'm sorry if I caused any trouble. And he's like, yeah, okay, well, I'm going to need you to come back and fill out an incident report. And so they dragged him back through the cafe up to the offices that were upstairs where he had to fill out a police report. And once again, he comes through the cafe and everybody's just like, mm-hmm. And he just told him, it's okay, the attack's over. And so he had to pay for the broken glass and was not allowed in the Museum of Art anymore after that. And what's more is that he didn't know it, but there was someone in the cafe that actually went to church with my parents and had known him when he was younger, who called my mom after that happened and said, I saw your son Chris today. Is he doing okay? Because he had a little bit of an episode in the museum cafe. And so we have never let him live this down. It's been 20 years, 25 years, and we still talk to him about the bee incident. My point in telling this story is that is culturally unacceptable behavior. And there is actually nothing that we respond more strongly to socially and will punish more severely and more quickly than behavior that is deemed out of the ordinary, right? If somebody doesn't respond properly, you will distance yourself from them socially, and it happens almost automatically. You don't even think about it. You just go, oh, that's somebody I don't want to deal with. Now, this can be a problem when you're dealing with people who actually do have disorders and difficulties that make it difficult for them to pick up on social cues. Those folks tend to be ostracized and have a hard time fitting in socially, and pay the price unnecessarily for socially unacceptable behavior. But you can see that is something that we come down on pretty hard. We want to know how people are going to behave in any given situation. It's important for us to know then how to respond. And if people don't follow the social scripts that are created in our society, then we feel really uncomfortable and we distance ourselves from them quickly. Now, even so the culturally unacceptable definition of abnormality is a larger aspect to what we talk about in psychology, but still not sufficient in and of itself, because there are different cultures, right? Think of if you were to suddenly go to some other place in the world that was a more collectivistic culture. Let's say that you suddenly found yourself living in China, for instance, which is a more collectivistic culture than we are. We tend to be more individualistic, right? We value as a society sort of going your own way and doing your own thing, right? The behaviors that are commendable in our society, some of them at least, are going to be problematic in a different society where you're not supposed to go your own way. You're supposed to fit in with the group and do your part and fit in. That is a place in which you can see the difficulty of, if we're talking about what is problematic behavior that needs to be addressed and treated and changed, you can't just take the cultural definition of abnormality, because it varies from place to place and time to time, and so it's not universal and is not a true marker uh, of the need for treatment. What we tend to focus most on in psychology is the definition of abnormal behavior, in which we look at the elements of distress and dysfunction. Is the behavior causing distress? Is it keeping the person from living a successful, happy, and otherwise productive life? If so, then that is likely to be something that needs to be treated, right? Now, you do get some, you do still get some aspect of cultural acceptability and how common is behavior when we're talking about treatment and when we're talking about defining abnormality within psychology. But primarily, we're looking at, does it cause distress and dysfunction? Generally speaking, we're talking about the person themselves. Is this person experiencing distress and dysfunction? However, in some cases, we'll talk, for instance, next week about personality disorders like antisocial personality disorder. Those folks don't experience distress and dysfunction in their own lives. It's the people around them that experience the distress, and because of that person's behavior. Now, those tend to be more difficult behaviors to treat, and again, we'll talk about that when we get to treatment next week. But usually we're talking about distress in the person themselves, but sometimes it can be distress and dysfunction in the people around them that has its basis in the person's behavior, and that's worthy of treatment as well. Okay, now we've been working on this for a while as psychologists, and at some point somebody far smarter than me and with far more better attention span put together the Diagnostic and Statistical Manual of the American Psychological Association, which is used as the Bible for psychological disorders in the United States, essentially. It lists all recognized psychological disorders, groups them by categories, and we'll talk about the different categories. We'll start going through some of those today, and lists the diagnostic criteria for those disorders. For instance, if you were to look at major depressive disorder, which is one of our primary depressive disorders, that is in the category of depressive disorders. And if you were to turn to the page that talks, or pages that talk about major depressive disorder, you would see a list of symptoms, and it would look something like this. The person seeking treatment needs to have all of these symptoms, and there will be a short list, and for major depressive disorder, it's, I forget exactly, but something like changes in mood, lasting 2 or more weeks, lack of interest in their usual activities, and there's 1 or 2 others that are like primary diagnostic criteria. So there's a short list of those. You have to have all of these criteria met. And then there's a larger list of probably 20 different symptoms that the person needs to have some subset of those symptoms. Person needs to evidence 3 of the symptoms on this list, in addition to these primary diagnostic criteria. So those would be things for major depressive disorder like changes in appetite, changes in sleep pattern, changes in speed of movement, physical movement, and there are a bunch of others. Thoughts of suicide, etc., etc. And so it is the clinician's job or the therapist's job to use these diagnostic criteria to say, okay, is this somebody who needs a diagnosis of major depressive disorder or whatever other disorder they're looking up and comparing with the person that they are dealing with? We are on the DSM-5, which was published in 2013. We're probably coming up in the next few years on a 5th edition revised, because they tend to put a new edition out every 10 to 15 years, so it might take a little while longer than that. As our understanding of the different disorders that we're dealing with improves and changes, some things get added to the DSM and some things get taken out. For instance, homosexuality was actually included in the DSM up through the DSM-3 in the 1970s. So at a certain point, the cultural definition of abnormality changed, and we learned more about what it means to be homosexual and decided, no, this doesn't belong as a psychological disorder, right? And so it was taken out. But you get more minor revisions all of the time in every single edition, where things will get recategorized, or the wording of the symptoms will change as we learn and understand more through our research about what's really going on with these disorders. Sorry, I've got a needy dog here that's trying to get up in my lap. All right. Now, just because you have a reference manual does not mean that everybody ends up with the proper diagnosis, because you're still dealing with the human factor, where there is a therapist or clinician who has this book in their hands. And how are they applying what they are seeing in the book to the individual that they are dealing with in the office? So you can have the same individual go to 5 different psychologists, and have 2 of them give them a matching diagnosis, and 2 others say that they need a different diagnosis, and then a 5th that says they need no diagnosis whatsoever. So there is still that human factor. I don't know that we ever want to remove that, because we seem to think that that is important as a society, and as humans, we like to prioritize our own thinking and judgment, especially when it comes to expertise. Nevertheless, that does introduce a level of variability in the diagnostic process that we haven't quite figured out how to get around just yet. Okay, now above and beyond just the using the DSM-5, there are other differences that therapists and clinicians have that will affect the diagnoses that are given and the treatments that are chosen. And that has to do with what is the primary perspective that that therapist adheres to. Do they pay more attention to the biological perspective? If so, they are going to view psychological disorders as arising from disorders or errors in brain function and in body function, and they are going to then seek treatments that address those errors in function, right? Whether that's medication or bioneurofeedback or some other biological intervention, they're likely to stick with that perspective, right? Somebody coming from a psychological perspective is either going to be in the psychodynamic perspective or perhaps the humanist perspective. They are going to view psychological disorders as arising from interactions from childhood with parents, issues that are buried in the unconscious mind, ways of learned interaction that are maladaptive, and are going to then diagnose and treat people according to that perspective, right? And so you can see some of the different perspectives that we have here. The one that we have tried to move more toward as time has passed in the psychological field of treatment is the biopsychosocial model of understanding disordered behavior, which, as you can hopefully tell from the name, tries to marry the other perspectives together to say, let's look at all of it at once, right? Let's look at what's going on in the body. Let's look at what's going on psychologically with the person. Let's look at what's going on in their environment, their social interactions, and their cultural interactions. And somewhere in the middle of all of those perspectives is the disorder itself, as it truly exists within the individual. And so the more perspectives you bring to bear, the better you're going to be able to triangulate on what is truly going on with that individual, what the actual disorder is, and therefore how best to treat it. And so this sort of multi-perspective approach is more and more common in psychology as we try to understand and bring as many tools as we have to bear on the individual so that we can help them to the best of our ability. It's also worth recognizing, before we get into the different categories of disorders, that not all diagnoses are created equal, right? You have probably known and dealt with individuals who have had diagnoses of depressive disorders or anxiety disorders. You may have even received one of these diagnoses yourself. If you know multiple people in this category, it's quite likely that they are not experiencing exactly the same symptoms to exactly the same degree. There is more severe and less severe levels of diagnosis. So you can look at it as a spectrum of functioning and of disordered behavior. If you're all the way on the left end here, as we're looking at this slide, then you are functioning normally within that domain and are not experiencing any difficulties. Then you can have mild or even moderate symptoms of the disorder in question without necessarily reaching the level of clinical diagnosis, right? So you probably know some folks who just sort of have depressive personalities, right? They just are sort of not super excited and get sad easily and struggle to keep up with their stuff, and they do all right though, right? They're still passing their classes and keeping their job and are able to get themselves out of bed in the morning. And so yes, they have some of the symptoms of depression, but they are mild enough that the person is still able to manage their life, right? But then you move more towards the right on this scale, and you start to get to the point where people can't manage their lives and do need a little bit of intervention and help and treatment. But even within those folks, there's folks who experience milder symptoms and those who experience more severe symptoms. Again, going back to the example of depressive disorders, you've got the person who is failing out of several classes and hasn't talked to anybody in a couple of weeks. And then you've got the person who is self-harming and planning their suicide and can't function in any domain in their life at all because their depressive symptoms are so severe. Now, that may be the same disorder, but those two people are not experiencing the same thing, right? One of them is much more severe than the other, and so it's worth recognizing just because you've had a diagnosis, you've dealt with something, and somebody else is dealing with the same disorder doesn't necessarily mean you know exactly what they're going through, because there is a definite difference in levels of severity that can occur. Okay, so talking about our different disorders, let's start off with the disorders that generally show up in childhood and adolescence. We've got two major ones here that we're going to talk about: autism spectrum and ADHD. Now, autism spectrum disorder, which was in earlier versions of the DSM just called autism, was then renamed because, much like the graph we were just looking at a second ago, there is a spectrum of severity that folks can differ on widely and still be experiencing disordered behavior. This was first recognized in the 1940s. By a researcher who was able to identify three basic categories of difference in behavior. The first was in communication. The second was in Oh, nuts. I gotta go back to my notes. I've forgotten what. I've got notes here. I usually don't look at them when I'm lecturing because I can remember this stuff. I've talked about it enough, but I sometimes forget. Okay, there it is. Social relatedness, communication, and ritualistic behavior. Okay, sorry about that. All right, so social relatedness, you frequently see differences in kids on the autism spectrum in their ability to relate socially to others. Uh, some of this, there have been biological differences that have been discovered in folks on the spectrum where they tend to have smaller amygdala. Now, we've talked about the amygdala as the fear center of the brain, right? It is also apparently one of the major parts of the brain that trains us to look for information, social information, in the eye region of other individuals. So, folks with a smaller amygdala will have a harder time looking other people in the eye, and as a result, have a harder time getting information about those individuals' emotional state and their social desires. And as a result, folks on the spectrum tend to have a hard time responding to social cues because they miss a lot of them. And so they tend to be awkward socially and maybe not in exactly the same way as the story I was telling about my brother, but behave in socially inappropriate ways that then tends to lead others to ostracize them, unfortunately. Once again, this is a question of brain function and what's actually going on in the body that appears to lead to these differences. As with the other domains that I'm going to talk about here in just a second, there are differences in severity, right? You get some folks on the spectrum who have a little bit of difficulty picking up on social cues and might be a little awkward occasionally, but still are able to manage their lives and interact fairly normally. And then you have those with more severe symptoms who miss all of it and can't participate in conversations successfully and have a hard time making friends, etc., etc. On the milder end of this social connectedness, you've got individuals experiencing what we formerly called Asperger's syndrome, which it now fits under the umbrella of autism spectrum, which is just mild deficits in social relatedness and sometimes communication, but otherwise high functioning. All right, now communication. This goes hand in hand with social relatedness, but is its own thing. You've got kids on the spectrum who vary all the way from very adept at communication, have normal language and communication skills, to those who are totally nonverbal, depending on the severity of the differences in their brain development. And so, once again, that just compounds the difficulties created in social relations. And last but not least, kids on the spectrum tend to have and engage in repetitive behaviors. Now, this can be hand flapping or rocking back and forth or twirling or any repetitive behavior of this nature. This, to the best of my knowledge, comes from the attempt to manage sensory sensitivities, which is a really common symptom of autism spectrum disorder as well. Kids on the spectrum have one or more senses where they are especially sensitive to input on that sense, and so get overloaded, overstimulated really easily, and tend to engage in this repetitive behavior to lessen the anxiety that is brought about by overstimulation, whether it's a question of not being able to handle normal levels of noise when out in public, or being overstimulated by visual stimuli. If things get too complex visually, some of these kids will have a really hard time. Others will have a hard time with tactile sensations, only be able to wear particular types of fabric, or you can have multiple sensory sensitivities. Anyway, it's easy to get overloaded for these kids and not be able to handle their emotions and the tasks that they are being asked to accomplish. And so they will engage in this repetitive behavior, whatever it is, to try to calm themselves down. And those are the primary characteristics of autism spectrum disorder. ADHD is the other one that tends to show up in childhood or early adolescence. And this one's a little bit more controversial in that you've got behaviors in ADHD that are common in all children. ADHD, as evidenced by the name, attention deficit hyperactivity disorder, is characterized by the inability to pay attention at an age-appropriate level and the inability to control your body, right? So these are kids who have to get up and move, they're disruptive, they can't sit still, they can't pay attention, etc. Now, depending on when you catch them, that's nearly all children, right? Kids have a hard time sitting down and paying attention. That is childhood. That just is how it works. However, while there are those who argue that ADHD shouldn't even be a diagnosis at all because of this, there are those children who have a harder time than their peers, right? And so it's not just I have a hard time paying attention, but in comparison to the other kids around me, I have a much harder time paying attention. I have a much harder time staying still. And there have been, once again, biological differences in terms of the thickness of the cortex of the brain, which is the surface of the brain. That usually reaches its peak the cortex usually reaches peak thickness in children right around age 7 or 8, if I recall. In kids with ADHD, they don't reach their peak cortical thickness until 11 and a half or so. And so there is a difference in terms of brain growth and development that appears to be related to the inability to pay attention and stay on task and sit still. The rates of ADHD have climbed drastically in our society over the last 20 years. We're at roughly 2% of children get diagnosed with ADHD. Overwhelmingly, it's boys. I mean, it's not all boys, but roughly 75% of diagnosis of ADHD goes to boys. And generally it is managed with medication. And once again, that's controversial because we're medicating kids that just need to run out and play. I think the two perspectives can coexist side by side. At least they do for me. I think it is possible that we are overdiagnosing and overprescribing medication to children, while at the same time this is a real disorder that people really do struggle with, and some kids need to be medicated for, right? If any of you have ADHD, I can probably take your ADHD meds out of your cold dead hands, I would imagine, because it makes it much easier for you to actually keep up in school and engage with people normally and whatever. So I'm definitely not one that says, oh, this isn't a disorder at all. Even as I recognize that there are profit motives in the pharmaceutical industry that bleeds over into the psychological industry that are somewhat problematic. Okay, let's move on to anxiety disorders. This is probably the last topic we'll cover in this video because it's starting to get long. But we've got quite a bit to cover here. So let's go through these. Our anxiety disorders, you can see all of the ones that we're going to talk about here on this page, are categorized together because they all share a common core of feelings of anxiety, right? Okay, so let's talk about these. When we're talking about the prevalence of anxiety disorders, you've got roughly 20% of Americans 18 and older that either have been diagnosed or could be diagnosed with any anxiety disorder within a 12-month span. And you can see the different ones as we break them out are lower than that. The most common ones being social anxiety disorder and specific phobias. Okay, let's talk first, though, about generalized anxiety disorder. This is an anxiety disorder in which you experience high and unreasonable, unworkable levels of anxiety um, that are not necessarily related to any one thing, right? These are individuals who worry about everything all of the time. And one of the difficulties of generalized anxiety disorder is that it's difficult for these folks to they will spend as much anxiety and worry and time thinking about what to wear in the morning as they do about where they're going to grad school or who to marry, right? These are all decisions and things to think about that cause very high levels of anxiety. Most of our anxiety disorders are adult onset disorders. They show up in late adolescence or early adulthood. And this is one of those. The symptoms need to last for at least 6 months before you can be diagnosed with generalized anxiety disorder. Yeah, it is treatable, absolutely, both through therapy and medication. But that's the primary symptoms that we're talking about. Panic disorder is an interesting one. Panic disorder is different from having a panic attack. I don't know if any of you have ever had a panic attack. It's super unpleasant. A panic attack is simply an episode where you experience physical symptoms of anxiety that become distressing. Racing heart, the inability to sleep, feelings of impending doom. Sometimes folks will even experience chest pain. Frequently, folks will check themselves into the hospital thinking they're having a heart attack when really they're just having a panic attack. Panic attacks themselves are fairly common. Roughly a third of American adults experience panic attacks at some point during their life. I've had a few. They're not awesome. Mine have been fairly mild, but I'll get worked up about something. Usually it's either my relationship with my wife or my work or something like that, and I just won't be able to go to sleep, and I have to get back up because my heart's racing and I can't stop, and I'll have to go for a walk, midnight walk or whatever, and it'll take me hours to calm back down. It's really unpleasant. It feels like the world's ending. Now, a panic attack is not the same thing as panic disorder. Panic disorder occurs when someone experiences panic attacks to the point where they begin to have anxiety about having a panic attack, to the point where they are changing their behavior to try to avoid panic attacks, to the point where they are experiencing distress and dysfunction because they can't do their normal activities because they're worried about panic attacks. This is somebody who, doesn't go out shopping because they're worried about being in public and being getting overwhelmed and having a panic attack, and that being embarrassing and painful and difficult. So, ironically, the anxiety about having a panic attack can trigger a panic attack. When you've got panic disorder, that's that sort of irony is part of the disorder itself. So once again, this needs to go on for a certain amount of time. If I remember right, it's 6 months where a person experiences not only recurrent panic attacks, but also the inability to manage their everyday life because they are not doing what they need to because they're worried about having panic attacks. That is panic disorder, right? It's a pretty uncommon disorder. I think if you look back in the slides here, it's 2.5% of adults. Now, agoraphobia is sometimes related to panic attack or panic disorder, except that it is not necessarily related to the fear of having panic attacks. agoraphobia, I always thought was just the fear of open spaces. It's actually a little bit more than that. It is the fear of being in a place and running into difficulty that you can't control because you are in public. Um, so it's not just being out under the open sky for most folks. It's being away from home. It's being in a public place, worried that you are going to be in a movie theater that is going to have there's going to be some a public shooter or something like that, and people then changing their behavior, stopping going out of their house for fear of something bad happening to them. And so these folks frequently become shut-ins. Now, this feels a little different in an era in which most of us are shut-ins because we're not supposed to go anywhere, because we're not trying to not get other people sick. Nevertheless, when it starts to interfere with normal everyday functioning, that's when you're dealing with agoraphobia. Okay, moving on. Specific phobias are irrational, unreasonable, unmanageable fears of a specific thing or event that cause distress and dysfunction. Now, we have names for some of these that are more common, like you've got arachnophobia for the fear of spiders. You've got folks who experience fear of needles, or, I mean, it can be anything, right? People can develop irrational, unworkable fears of anything, of dogs, of fish, of water, of whatever. And if it's something that causes them enough distress, then that is something that can be diagnosed as a specific phobia. Now, I want to specify here, this is actual distress and dysfunction, not just somebody having a quirk. So, for instance, anytime I go into somebody's bathroom, or even my own, I have to pull back the shower curtain, because if I don't check, there's probably going to be a dead body. I don't know. I just got that in my head sometime, and it stuck. And so I always just check behind the shower curtain. Now, this does not cause me distress and dysfunction, right? I am still able to go to the bathroom, even if I haven't checked behind the curtain. I just prefer to. It's my thing, right? Now, if I avoided going to the bathroom, avoided using the bathroom, and got sick from it because I was so worried about checking behind the shower curtain, that might qualify as a specific phobia. But as it is, it's just me being me, right? And we've all got our own idiosyncrasies. But it is worth sort of thinking about how you talk about things. Phobias, this is a word that we use really casually in everyday speech. I talk about my phobia of needles, or I used to talk about my phobia of needles because I don't like getting stuck with needles. Well, guess what? Nobody likes getting stuck with needles. If I go to the doctor, I can still get my blood drawn, and I'm not going to freak out. I will be okay. I don't actually have a phobia about it. And saying that I do, when really it's just me being a wimp, lessens and sort of invalidates the experience of people who truly do experience unreasonable, irrational fear that keeps them from doing what they would like to do, right? So it's worth thinking about how you talk about some of these things. I'll talk about this again when we talk about OCD here in just a second. Social anxiety disorder is could be considered a specific phobia because it is the fear of meeting new people and being in social situations. It is the most common specific phobia that occurs within anxiety disorders. It turns out that lots of us have a really hard time meeting new people, speaking in public, and in other ways presenting ourselves to people that we don't know. And that's something that we're asked to do all of the time in our society, and it's really difficult for some people. And fortunately, it's something that is susceptible to treatment. You're not stuck with it. You can get treatment and you can work on this stuff, and it does get better over time. So, okay, PTSD. Once again, you may not necessarily think of this as an anxiety disorder, but at its root, it is the fear of a traumatic event after it has occurred, right? So, as you can see from the slide here, the most common scenario in which this occurs, or the one that which we think of the most, is folks going to war or in some other military action that then come home and have a really hard time readjusting to everyday life because they are hypervigilant against all sorts of things that aren't actually dangerous because they remind them of the traumatic experiences that they've gone through. I actually got a guy that I go to church with who's an older gentleman who was in Iraq back in the 90s, and the transport vehicle that he was in got blown up by an improvised explosive device. And he has experienced all sorts of negative health. I mean, he's got terrible problems with his back and his legs and all sorts of things because he got blown up. He has also talked some about the PTSD that he has had to deal with, where he has and continues to have a hard time in certain situations because he will flash back to these terrible events that happened, not just the explosion of his Humvee, but also some of the other sort of combat situations that he was in. He will awake from terrible nightmares and find himself out of bed, looking for weapons, looking to attack somebody, and worries about the safety of his family. The characteristics, the criteria for PTSD is you need to experience recurrent fear of and thoughts of a traumatic event after it has occurred that then interferes with your everyday functioning. Frequently, these folks will experience what we call generalization, where anything that is even remotely similar to a traumatic event then triggers those feelings of fear and need to defend themselves and to get out of the situation. My grandfather, my dad's dad, who was a World War II vet, to the end of his life could not come outside during 4th of July because the sound of firecrackers would make him flash back to his time in the Pacific Theater of War, and it made him really uncomfortable and very stressed out, and so he'd just stay inside. Now, while we tend to think of soldiers being the primary folks who get PTSD, it can happen due to any traumatic event. Unfortunately, lots of folks experience PTSD, lots of women especially experience PTSD after a sexual assault, and or a scenario of abuse. That's not just women with abuse, obviously, but more common amongst women than amongst men in that scenario. It doesn't matter what it was that happened. It can trigger the occurrence of PTSD in the individuals who experience them. If it causes these intense feelings of anxiety and fear and the need to seek safety, then that's PTSD. I have a friend who got non-Hodgkin's lymphoma at age 25 and underwent chemo for 1.5 years and was treated for PTSD after that because he kept flashing back to his experiences going through chemo and was having a hard time. Couldn't handle his life. Got better, right? He was able to get therapy and get over a lot of that stuff. But it's not just the obvious things that cause PTSD. And another thing to think about, and this is something that we're still studying and trying to figure out, the same event can happen to two different people, and one will develop PTSD and the other will not. Some folks simply seem to be more resilient when it comes to their psychological functioning, and they get over these things and don't develop these fears and flashback problems that folks with PTSD get. And even at different levels of severity of trauma, you can have differences in who develops PTSD and who doesn't, right? You can have very, very terrible things happen to two different people, and one of them will get PTSD and the other one won't. You can have something that from the outside looks relatively minor, and somebody can still develop PTSD from it because we don't know how they are actually experiencing it, right? At any rate, it is the core of anxiety and fear that causes us to categorize this as an anxiety disorder. Okay? All right, I'm going to go ahead and leave it there. We'll come back next time and talk about mood disorders and several other categories as well. Okay? Thanks, everybody. We'll see you in a couple of days.